I've been doing a few videos on Botox brow lifts recently, and a lot of people are asking about older patients. Now, older patients are much trickier when it comes to lifting eyebrows for a number of reasons. Typically, it's because as you age, there are multiple variables that change, and patients are extremely different. So you'll have some patients, for example, who have hyperactive eyebrows, lots of movement, and if you do a brow lift on them, they can actually become exaggerated. So your Spock brow type or Joker type eyebrows that are just hyper elevated is actually easier to do in an older patient than in a younger patient. And that's because they lack the fat pads that cause a cushioning of the muscle. So the muscle is unopposed, and as you increase the resting tone of the muscle without any fat to resist it, you can get a much more arched eyebrow. The problem with these patients is then when you try and soften that, it's actually quite easy sometimes to cause the other problem, which is they drop. And this is what makes eyebrow lifts with botulinum toxin in older people more difficult. Now, of course, you can do it. I've had many great results in patients that are older, which I would classify as anyone 55 and older. They become harder to treat, but it's still possible. And really the nuance with this comes with getting to know the varieties of anatomy, the types of patients, and the difference that happens with different kind of volumetric changes in the face. Some people will have excess fat pads as they get older, and others get much thinner, and they're very, very different to treat. I would say it's probably easier to treat patients who have excess fat pads, because all that you get then is a slightly disappointing result. Whereas the patients with very little fat in their face, you can cause quite shocking results that all their friends and family talk about in a bad way. And this is really worth thinking about. How do we get around these two different scenarios? Well, the first is an older patient who you don't think you've got much chance of lifting. You're probably fine in most cases, just to be completely honest and say, you may not get a great eyebrow lift, but I can do the injection patterns that should cause an eyebrow lift. The worst case scenario is it'll soften some of your lines and you'll get a very tiny lift. But there isn't really much of a risk of causing too much arching in someone is not that easy to lift. The other patients are trickier because you've got this balancing act, and they can ping pong between too much lift, McDonald's shaped eyebrows, or the other way around where it collapses and they look heavy and sad, and both make patients quite unhappy. And the injector needs to learn about how to grade eyebrow lifts. With practice, knowing that you're leaving a certain amount of the frontalis untreated, you can vary the amount of lift and you can almost fade it in. It's a bit like hairdressers do with great haircuts. They can fade them in. And you can do the same thing with botulinum toxin, particularly around the top of the arches that we treat in the cat ear shape that I teach. And it's in these patients where you can learn with time how to vary the depth or the strength of the injection relative to the muscle that you want to leave untreated. So you get varieties of softening of the eyebrow. In its simplest form, if you had someone with a larger forehead who are easier to lift, and you draw the cat ears and they go all the way to the top, all you do is put one unit lower down in that section. Now, if they still have a very strong muscle and they're very low in volume in their face, they might still get too much activity. And this is where you learn the little adjustments. So you could put 2 1-unit injections lower down in the cat ear and one at the top, so you're fading it slightly more. Or you could put 2 units right in the middle of that cat ear and allow the spread of that toxin to change slightly as you get lower down towards the eye. But it really comes down to finessing that area of muscle so that we're taking away just enough so you get a little bit of brow lift, but it's not so strong that you get the ladder lines, or as millennials call it, the Wi-Fi lines. Once you realize it's this finessing approach rather than an exact injection point, you should over time figure this out by making small adjustments, seeing the result and learning from it within each patient, but also collectively between all your patients, because you then get better at predicting what each patient needs. So what do you do for an older patient who has hooded eyelids? It's very important to distinguish between actual eyelids versus a brow that's pressing on the same area. Because if you have skin that is connected all the way down to the eyelashes, so there's one continuous sheet without this periorbital sulcus, then you will end up with skin that rests on the eyelids that's about the frontalis muscle. And those people, you might be able to create some lift, but they're also particularly easy to drop and make the problem worse. So in particular, if you ever see patients who want to treat horizontal lines and they have this shape of skin where the skin is continuous all the way to their eyelashes, they're very, very easy to upset, because if you cause a brow drop, even a millimeter, they will feel it. So they are also the patients that if you cause a brow lift, they're going to get some benefit. There is a cohort of patients who have genuine eyelid drops. So as you get older, some patients' eyelids actually get heavier, and you're unlikely to affect that at all by treating the frontalis or the corrugators or the orbicularis oculi. There's a chance that you can cause a small lift by treating the actual orbicularis oculi that's on the eyelid, as you would treat a ptosis. Some people are now doing this, where if you get a ptosis, you inject Botox near the eyelashes. That's a potential way that you might cause a small lift. But I've never seen it used so far in an older patient with an age-related eyelid ptosis, but I can't see any reason why that wouldn't work because it is affecting those muscles that balance the eyelids. So do you need to make changes to dosages when injecting older patients? In many areas of the face, it's a very similar strength muscle with different levels of supporting tissue. And this doesn't always make a difference. I don't think it makes a great big difference when you're treating the glabella on a 68-year-old as opposed to a 25-year-old. Similar dosages, if you want a little bit of movement or no movement, you're still going to have to treat in a similar way. Now that's very different with the frontalis and potentially with the orbicularis oculi because there's less support for the tissues in other ways. Probably the best example is orbicularis oculi, because when you're treating crow's feet in an older patient and you just relax the muscle, it's very easy to relax the muscle and improve the lines. The problem is that as you get older, the degree of support relative to the other structures that the muscle gives the cheek is higher. Essentially, the orbicularis oculi is supporting the cheek. And so if you use the same dose in a younger person, it makes them look older. They actually sag. So you get this sad look as the cheek descends because the orbicularis oculi is no longer supporting the cheek in its resting position. So that's the most important thing to think about with older people. There's a point at which the muscle is so much more important for supporting the other structures. So I include eyebrow and cheek, that you would not want to treat it at all. And you'll get this feeling when you see a very old person whose skin is very, very lax, that botulinum toxin on its own is probably, although it will get rid of the line or the wrinkle, it's going to cause a ptosis somewhere, either a cheek or a brow ptosis, even with very low doses. And trust your instincts on that. If there's no support there from other tissue, it's better not to treat. And of course, then there's this gray area in between, which is where experience really comes in. You have to pay attention to patients. The degree of skin laxity and how much Botox you put in would change accordingly, to the point where you should put very, very low doses in older people, or even further beyond that they are not appropriate to treat at all, particularly with frontalis and orbicularis oculi. So in summary, I hope that's given you more to think about in terms of how you treat your older patients, and acknowledge some of the difficulty with this area, because it isn't as straightforward as treating our typical patients who are probably around 37 to 43. Those older patients do require more thought, and I hope I've given you some structure to approach that with. Thanks for watching. Don't forget there's a download that comes with this if you want to learn more about different Botox injecting patterns at the bottom of this video.